Hi, okay, I'm going to go through the PowerPoint for exam 2. It'll be open until this Saturday. And for the exam format, it covers chapters 6 through 11. So it'll be, again, 100 points, and you'll have 90 minutes to complete the exam. There's going to be a total of 42 questions. These will include written responses, matching to a category, and multiple choice. So for the written response, you'll want to be able to list things, define terms, and give your opinions on what you think about certain cases. So there'll be some cases presented on the exam that you have to read through and answer multiple questions about. And then you should also be prepared to read an audiogram and then determine the degree and type of hearing loss. So make sure to review that information. So for the first part, we're going to just kind of talk about the difference between lip reading and speech reading. So lip reading is a person is only relying on the visual and the visual signal for recognizing speech, and then for speech reading, they're relying only on the auditory and visual cues, and this includes things like expressions, gestures, the context, and stuff like that. Right, so then we are going to cover the characteristics of a good lip reader. So you're not able to predict who will be good at it and who will not be good at it, and it's not able to be predicted by your abilities either, such as your intelligence, your educational achievement, the presence of and the duration of the acquired hearing loss, the age of hearing loss onset, or gender or socioeconomic status. So none of these will be able to determine who's going to be good at it and who's not going to be able to be good at it. But things that can can be characteristics of a good lip reader are things such as their working memory, their visual word decoding, so the rapid transmission of neural impulses from the eye to the brain, so how quickly you can see their mouth moving and your brain register what is being seen, and then their lexical identification speed, so does a particular string of letters sees a word, and then also looking at linguistic and worldly knowledge, and then also your age can be a factor, and if the good close skills or verbal inferencing skills are present, and then their willingness to guess, and then reverse interpretations. And then some variabilities that influence the difficulty of lip reading. This will include the visibility of sounds. So just keep in mind that 60% of speech sounds are not visible on the mouth. Also, the rate of speech. So the human can only register about 9 to 10 discrete mouth movements per second. And co-articulation and stress effects. So both can change the way sounds look. And then homophones and vasemines, the speech sounds that look alike on the face are vesemes, and then homophones are words that look alike or look the same on the mouth. So just be able to differentiate the two and which one correlates to how your face looks and which one looks the same at the mouth. And then talker effects can also impact this. So sounds that can look different as a result of the person's culture, geography, location, their appearance, or their disposition. So the impacts that that has. And then how does speech reading help? It's residual hearing is still possible in low frequencies for severe slash profound hearing loss. So auditory training can help pair the visual and auditory signals together, and then amplification assists in detecting the prosodic aspects of or suprafragmentals of speech. And then some factors that are going to influence speech reading. The talker, these are those four ones. So the talker talker's behavior, your familiarity with the talker, if it's male or female, the message, so the sentence length and complexity, the frequency of use, lexical neighborhoods, and lexical content will all play a role in it. The environment, so the angle you are seeing the person at or viewing them from, if it's straight on, if it's to the side, the distance you are from the talker, room conditions such as lighting and background noise to what's going on in the environment. And then lastly, the speech reader variables are their innate skills, their hearing acuity, emotional state, visual acuity, and physical state. So all of those will be impacting them as well. And then speech reading training candidates include children in total communication programs, adults recently who have acquired a hearing loss, advancement of hearing aids, cochlear implants, and then ALDs, so assistive listening devices, and then anyone who can benefit from speech reading training. So rules for speech reading training, kind of the general overview is you want to make sure you're watching their lips, and when you're like working with someone, you want to be giving feedback to the speaker. You want to adjust the environment if it's possible. So back to the feedback to speaker, like let them know what is working well, what isn't. You want to minimize the background noise, so close doors or do it in a quiet space if possible, and then know the topic you are going to be discussing, and then pay attention to context clues, and always remember to stay positive. It's a really important factor. I think it's often overlooked. And then for the goals and outcomes of oral rehab, we have alleviate difficulties associated with the hearing loss and minimize the challenges of hearing loss as the goals. And the outcomes you hope is for improved conversational fluency and reduced communication limitations. So, characteristics of conversation with a person of hearing loss. So, this can include things such as disrupted turn taking, modified speaking and listening styles, modified conversational styles, less rich imagery when they're talking, inappropriate topic shifts, superficial content, so they're not really getting down to the deep, more detailed, important information, frequency of clarification. They're going to be asking you to repeat yourself a lot or saying what or unsure, and then violation of implicit social rules. So this kind of goes back to that inappropriate topic shifts and that disrupted turn taking and just not really following the typical pattern of conversation, or maybe like not replying because they're just really not sure what you said, and then disrupted grounding. So for communication strategies, there's the two. There's the facilitative strategies and then the repair strategies. So these facilitative strategies influence the listener, talker, message, and environment. They are proactive efforts to facilitate communication or conversation and prevent breakdowns in communication. So this is starting before the communication is happening. You're wanting to clarify things and just make sure you're in the best position to communicate. And then for repair strategies, sorry, that should be bolded more. These are things like implicit efforts following a communication breakdown. So these repairs are happening after that breakdown, whereas facilitated is before. You're receptive if the person with hearing loss does not understand, and then expressive for the person with hearing when the person with hearing loss is not understood. So there's those two different forms of the repair strategies within that. So the receptive versus the expressive. Maladaptive strategies. These are strategies that are inappropriate for coping with difficulties caused by hearing loss. So examples of this include bluffing, withdrawal, dominating the conversation, anxiety or tension around having conversations, self-pity, anger and hostility, and then denial of their difficulties and the frequency of their communication breakdowns. So, for repair strategies, um, receptive repair strategies, it's with a person with the hearing loss does not receive, or it's when the person with the hearing loss does not receive or understand the talker's message. And then there's the specific versus non-specific, so asking directly questions what you're not understanding rather than being unspecific, like just like huh or what. Like if you're specific, you say like, I heard you mention your granddaughter, but I didn't hear how old you said she was. And then if it's not specific, it's just like huh or what, or those really general things that they're not really sure what you didn't get. Um, so then expressive repair strategies, a person with the hearing loss does not express a clear message. So you're asking them to clarify a little bit more. And then also the 3 conversational styles that people might fall under are passive, aggressive, and assertive. So conversational fluency is relating to how smoothly conversation unfolds. It discusses communication breakdowns, the exchange of information and ideas, and then the sharing of speaking time, and also factors in silence. So for high conversational fluency, your conversation would have minimal communication breakdowns. There would be an exchange of information and ideas completely and easily. And then there's a shared amount of speaking time and pretty minimal silence in these conversations. And then for low conversational frequency, there's going to be numerous communications breakdowns. There will be like a very limited exchange of ideas between the speakers. And then one speaker really tends to dominate the conversation, and there is a good amount of awkward silence. So, a couple ways you can measure conversational fluency is through MLT rate, prolonged pauses, just measuring the amount of pauses in between speaking, the number of restarts someone has, how many topic shifts there are, how many times that one person interrupts the other, and then the level of abstraction and superficiality, so how detailed they are in their speaking or if they're being very superficial. And then the presence of self-consciousness, if you can kind of see that that person has a lot of anxiety when it's their turn to speak or just not really confident in what they're hearing. And then their degree of understanding after the conversation has been completed. So, to assess communication difficulties, there's a couple ways to do it. It can be done through interviews, questionnaires, have the person do daily logs, through group discussions talking about their difficulties, and then also through structured communication interactions and unstructured communication interactions. So for communication training or strategies training, for the communication strategies, think about auditory training, speech reading training, speech and language therapy, and then academic skills and literacy. And then it's really going to be important to know self-efficacy, and it's a person's confidence in self. So their mastery experience, their vicarious experiences, their verbal persuasion and emotional arousal, and how those all will be factors in how someone views their self-efficacy. So model for training with communication strategies is the 3-stage process. So there's the formal instruction, guided learning, and then real world practice. So stage 1 for formal instruction, you're going to be giving them specific information. You'll be very overt, direct. It will include a lot of explaining processes and things like that. And then in the guided learning, it's going to be more encouraging the participant to use these strategies you learned about in the formal instruction in the structured setting, and kind of increasing difficulty with that as you go, and to prepare them for the third phase, which is real world practice. And you're using these strategies in real life settings out in the world, and you're having them reflect on them, tell them see what they liked about it, what went well, what was difficult, how to make these changes. And you will go back and forth between all these stages to adjust. And then for short-term training, long-term training might not be an option. So this is kind of more focused on providing materials and self-directed instruction and providing a short tutorial. It just might not be possible for someone to do an extended program for multiple reasons, which is why a short-term training program might be a better fit for them. And then know the WATCH acronym and what it stands for. So W, watch the talker's mouth. A, for ask specific questions. T, talk about your hearing loss. C, change the situation. And A, acquire healthcare knowledge. So training for frequent communication partners is really important. It can help create appropriate speaking behaviors between the two. It can create empathy for the other, and helps with organizing the message better. And you can confirm your comprehension for the other person and then use those repair strategies. So for training for children, there is a 5-step model for expressive repair strategies. So step 1, understanding the process, how hearing works, what conversations look like. 2, understanding breakdowns, what a communication breakdown is and how to identify that. And then how the child should be formulating the message. And then introduce the repair strategies and then practice the repair strategies. So tinnitus. So tinnitus is a ringing, buzzing, or other sounds in the ear. About 200 health conditions are associated with tinnitus, which also can occur without a disease present. And then there's no known cure for it. There are a couple treatment options: relaxation techniques, biofeedback, acupuncture, counseling, and herbal and pharmaceutical treatments, but those are not FDA approved. And kind of thinking about the journey of a hearing loss, there's the 6 stages, kind of the pre-awareness. So others may notice the hearing loss, but the individual doesn't. There's the awareness, where it might happen gradually, where you start to see what the other people around you are talking about. When you realize the impact that your hearing might be having on conversations. Movement is the third part. You start thinking about taking action and work towards going to see the audiologist. And then there's the diagnosis, where you get the audiology evaluation and go through case history. And then there's the rehabilitation, so counseling, hearing aids, speech reading, communication strategy training, all that type of stuff. And then there's the resolution. So adjusting to the ramifications of hearing loss. And you really want to consider where the client is along this journey when you're going through this process. So psychological adjustments of hearing loss diagnosis: the person might be in shock and disbelief. They might be feeling some depression, anger and guilt, and then also the acceptance. So the acceptance might not occur at one specific point, and it could also never occur. Patients may have acceptance on occasion, but not all the time. It can be a very up and down kind of phase. So for the hearing loss journey with adults, hearing loss is not just in older adults. All ages can have a hearing loss. 19% for men have a hearing loss between the age of 48 and 59, and then 7% for women between ages 48 and 59. And then prevalence is increasing in younger adults as well. So the goals of AR, there's 8 of them. Information and education of hearing loss, learning about the environment, hearing aid use and assistive listening devices, communication strategies training, frequent partner training, psychosocial support and counseling, speech perception or auditory training, and speech reading. They kind of want to target all of these areas through AR. And some people might not need some, and some people might need all of them. It just kind of depends. So AR plans for adults. There's going to be the informational counseling, supporting efficacy and encouraging motivation. So there's the hearing aid evaluation. So you look at the patient's needs and motivation, see if they would be a good candidate for it. There's the hearing aid fitting and orientation. So then there's the hearing aid use patterns, and there's 3. There's the full-time users, those who reject it, and the intermittent users. And then hearing aid use patterns is crucial because that's when you determine how well a person is using. So this is really important for the follow-up appointments. So the first follow-up fitting should be between 2 to 4 weeks after the fitting. And then the second follow-up should be between 4 to 6 weeks after the fitting. And then follow-up continues every 6 to 12 months as determined by the patient and audiologist and how they feel. So some goals and types of counseling. So the goals include enhancing an understanding of hearing loss and the process, better self-disclosure, being aware of yourself, communication strategies, and then reduce stress and discouragement, along with increase the satisfaction with services. This should not be a side effect. This should be a side effect, not a goal. You want to increase the adherence and compliance with the oral rehab plan. So for types of counseling, there's informational counseling, so that's heightened understanding and providing facts and ideas, just explaining processes, exactly what is going on from a physiological standpoint. Personal adjustment counseling, so from a cognitive point, you address the faulty thought process of the hearing loss that some people might have. Behavioral, you need to unlearn maladaptive behaviors that could be impacting a person, and then affective, so fostering feelings and emotions. And then there's the psychosocial support, so dealing with the person's self-image, how stress and their response, stress related responses to hearing loss, social withdrawal that might be happening because of a hearing loss, changes in relationships that might be the cause of a hearing loss, and then also communication breakdowns. So for demographics of older adults, the population 65 and older has increased from 30 million in 2000 to 40 million in 2010, and it is projected to increase to 55 million in 2020. The older population represents 13.1% of the U.S. population in 2010, and this is greater than 1 in every 8 Americans. And the number of older Americans increased by 5.4 million since 2000, and compared to an increase of 8.7% for the under 65 population. And there are more older women than men, particularly among those over 85. And 48% of older women aged 65 plus live alone. And in developed countries, the most rapid growth in aging population is for racial or ethnic minorities. Prevalence of hearing loss with older adults, 54% of the population of over 65 have some hearing loss. And then hearing loss is the third most common chronic condition for those over 65. And then men experience a greater decline with hearing loss. And most individuals wait 5 to 7 years before seeking treatment. For older adults, patient-reported symptoms often include I can hear but not understand. People mumble, they don't articulate clearly. Young people talk too fast. And I do fine one-on-one, but if more than one person talks, I have difficulty. So effects of a an age-related hearing loss. Other individuals' speech is perceived as mumbled or slurred. It's hard to discriminate high-pitched sounds, such as the s, th, and f, which are those high-frequency sounds. Difficulty understanding conversations, especially when there's background reverberation. Certain sounds seem annoying or overly loud. And you also might have trouble perceiving rapid changes in speech or impaired localization. And there can be extraneous concentration leads to fatigue and thus requires a longer recovery time. So if someone is in a setting where it's very noisy and they're having to work a lot harder to concentrate, which leads to fatigue and can also oftentimes result in that social withdrawal. And tinnitus can be co-occurring. So it's important to know that there's changes in the brain as you age. So the nerves and pathways, they demyelinate, and there's a decline of transmission along the auditory pathway. There's a loss of neurons, there's reduction in synapse connections, and there's changes in neural transmissions along the auditory pathway that impacts localization and complex processing of auditory signal, and also decreased working memory. So factors to be aware of for the older populations and other populations as well is economic hardship, financial resources. It's good to think about that. Insurance, medical coverages, cost of these services, social implications, families, friends, community volunteerism, their living arrangement, things of that nature. If there's relationship changes, they become a grandparent, they're newly widowed, if they're a caregiver, if they are just a widow and have been for a while and their decline of their hearing loss is starting to impact them more. And then the emotional impacts, mental health, their temperament, independence, self-sufficiency, and self-concept. So, for hearing aids, cochlear implants, and assistive listening devices, you need to determine if the hearing aid, cochlear implant, or ALD would be appropriate given all of the variables the person might have. So patients' options should not be limited based on cognitive function, but rather that their cognitive function should be considered when choosing the appropriate amplification option. And then a patient in hospice care should not undergo a cochlear implant evaluation or a hearing aid evaluation. Rather, they should be fit with a loaner, if possible, ALD, such as a pocket talker. And then a patient with memory issues, strong supportive or minor memory issues, strong family support, and excellent motivation can be considered for an cochlear implant evaluation if audiologically or medically appropriate. And then typically with memory loss issues, it can still receive significant benefit from a cochlear implant, but will not achieve a poor level of speech perception compared to an individual without memory issues. That's all I really have for you. If you have any questions, you can email me, but otherwise, good luck studying.